Three, two, one. Needlepod.
Needle pod.
Not any better. Welcome back to Needlepod. This is our third time miking up. I guess we should introduce ourselves each time. My name's Paul Caloran with my co-host, Dr. Ellie Melrose. Needlepod, we're here talking all things dry needling and some things probably that are not dry needling related. Welcome back.
Okay.
Ellie, at this point, I mean, this podcasting platform is pretty slick. It does the recording. You and I just hop on and record, and it does a lot of the stuff for you. But one of those things, if you have seen us on social media or just like the little teaser clips, is that we can AI ourselves as little babies or Muppets, or there's lots of cool things. So first of all, I did an Instagram poll and it was pretty close to 50-50, but what do you like yourself better as, a Muppet or a baby?
I think the baby, although I was trying to compare it to like what I actually looked as a baby and it was not very accurate, but I thought those were really cute. But yeah, I guess the baby is what I would choose.
Yeah, I agree. I don't think it looked like baby me, but it was pretty convincing that Jen, my wife, when she saw it, she's like, that looks like a mix of Aiden and Wesley, who are our boys. Obviously they're related, but they actually look pretty different. Like Aiden, blonde hair, blue eyes. Wesley looks a little different, hazel eyes, brown hair. So, but it did kind of look like a nice mix of the two of them.
Combo. That's cute. I'll have to look at it from a new light of looking at the picture, comparing it to my kids and see if there's any resemblance.
Yeah, but the AI is not perfect. I mean, that first episode, if you saw a clip, like I think I had my finger up for like 1 second during that episode, but the baby AI is just like finger wagging the entire time. It's a little distracting.
So funny.
I apologize for that. Let's see. At the time of this recording, you are ramping up to send the very first pelvic dry needling course on your home turf in Fort Collins, which means in a month when this episode drops, it will be water under the bridge. You'll be a seasoned vet. So what, sitting here right now, would you like to tell your future self?
Goodness, that's a good question. You didn't prepare me for this question,
I got way
Paul.
deeper on you real quick.
That it's gonna all work out. I think what I'm most nervous about is timeline of like knowing how long everything's gonna last. And I think I have it set up a good chunk. I have some flexibility built into the days of like needing to move something to day 2 if we need to. And that's what I'm most nervous about, is making sure it flows nicely. But I have a really good crew in this first cohort. I have 3 or 4 other faculty taking the course, which is abnormal. And then I have a handful of people that I know from other previous courses as well. So it's going to be a really forgiving crew this first time around. So, and I'll get a ton of really good feedback, I think, from having those faculty members here. So it should be a pretty fun course.
For sure. I can't wait. I'm not going to be on it, but I can't wait to hear. I have seen you prepare it behind the scenes. I mean, over a year at this point of the research, the techniques. I mean, how you've packaged it looks awesome. And I mean, if you've taken upper and lower from us, or honestly, if you've taken dry needling anywhere, your kind of first layer of learning needling is just like, this muscle, or like this technique. Like what I really love, what I think people are going to love about your pelvic course is that you package it more on like pathology, I guess, or like this condition and this condition. And obviously different regions, you're talking different things, but everything from needling the actual pelvic floor to de Quervain's mom's wrist stuff. Like if you see pelvic folks, but really just if you see postpartum folks, I would say that this is the course to become the expert in all the needling things.
Yeah, and we dive into male pelvic as well. It's not as broad of a topic in this course that's coming out, but we do talk about it, and there's some really good research in improving different brands of male pelvic floor dysfunction. So lots of fun.
Love it. Can't wait to hear. I'm sure we'll talk about it more. And honestly, my question for today's episode your brain's probably going to go back into that pelvic realm, but try to think of the best way to phrase it. It sounds negative, and I guess the question is, but it only frames positive clinical implications. And the question for today for you is, if you were not allowed to use your needles, your needling and e-stim, for a certain very specific patient presentation or diagnosis. You can still use it for all the other stuff, but the needle police just came down and said, you cannot use needling for fill in the blank. What would you struggle to treat if needling was taken away from your toolbox?
Yeah. love this question. And I have two pelvic patient personas that come to mind. And I think for different reasons. So I had a client today, this morning, who is 4 years postpartum, has been to multiple other pelvic floor PTs, has tried transcutaneous muscle facilitation for the pelvic floor muscles, and still has a very poor power output for the pelvic floor. So we scale those muscle contractions, right? 0 to 5, 0 being no motor recruitment, 1 being a flicker of motor recruitment, and then it kind of ascends from there. And I would say she's living around like a 1 out of 5 when she originally came
A
in.
flickering contraction.
A flickering contraction, like it's there. She requires a ton of tactile feedback. So like pressing on the pelvic floor muscles, and that helps to, get the brain to activate these muscles. Those patients do so well with the test retest following dry needling. So doing an intervaginal assessment of the pelvic floor strength, layering in needling. And typically, where I will start with pelvic floor needling is not even all of the muscles that are struggling, but I typically will start with an obturator internus needle and an iliococcygeus needle. One, those two muscles straddle the pudendal nerve. So it's going to get like improved firing towards all of the other pelvic floor muscles. It's a great pump. And then that iliococcygeus is a big portion of levator ani, which is the deepest layer of the core canister in that pelvic floor. And when we do that, we layer in different Easton parameters for that neuromuscular priming, but also just get some input with a lower alternating frequency as well, and retest afterwards. She was able to improve her motor output to like a 2 out of 5 on day 1, right? And so I think that patient, prior to using pelvic floor dry needling, would have taken so much longer to get that initial recruitment strategy on board. And so I think that's kind of one of the patients that I have struggled with in the past before I was able to, or before I started using pelvic floor dry needling. And so that's one. Can I do a
Love it.
second one?
I'd love to hear it. Yeah.
Okay. Another one's pudendal neuralgia. So I think
Unpack how that
anytime,
presents for those. I know the pelvic crowd is tracking, but what does that look like walking through the door?
yeah. So pudendal neuralgia, typically numbness, tingling in the groin. We're not going to have like a full saddle paresthesia like you would see with cauda equina symptoms. Potentially in both female or male, we might have some sexual dysfunction on board. So either difficulties with arousal, difficulties with erections, and then in some cases also some issues with urinary or bowel dysfunction. So it's all everything that's kind of down the line of the pudendal nerve that innervates all of the pelvic floor muscles, the external urethral and external anal sphincter. Those are all going to be affected if we have excessive compression on the pudendal nerve. And so a big patient population that you'll see this with is with cyclists. So they have a lot of compression right on those ischial tuberosities and typically medial to them. They also are typically fairly lean, so they don't have a lot of subcutaneous tissue in their ischial-anal fossa. So we just have more compression on the pudendal nerve there. And without dry needling, again, things just take a lot longer. So yes, we can improve the nerve's mobility with manual techniques and getting that pelvic floor muscle to relax, getting the pelvic floor muscles to pump, like pumping around the nerve can really help with that tissue mobility and can improve things. But if we have any degenerative effects of that nerve itself, we can see a ton of improvement with trying to stimulate the pudendal nerve itself. And so again, typically where I'll start with folks is just same sort of technique as with the previous case, but obturator internus, iliococcygeus, getting a good pump to that pudendal nerve. If they have specific branch dysfunction, so if they had rectal pain because of it, we might want to target the rectal branch of the pudendal nerve. So needling around the anal sphincter where we can get puborectalis, pubococcygeus on board. There's so many different places that you can impact the branches of the pudendal nerve or the pudendal nerve that you can't get with your finger, right? And so the precision of the needle really helps kind of move the needle with that case. So
I
those
can
are kind of the
only
two go-to.
imagine.
Yeah. But
You just combined more anatomical structures and things that clearly in a realm, in a region that I am less familiar, that I have never personally.
You're
I
just
haven't
nodding and smiling.
I haven't said a lot of those words, and then when you land on the you can not reach it with a finger, it's outside of my comfort zone.
It is
But
my
I
bread and
mean,
butter. I love it.
but what I hear from people constantly in that realm using needling is, man, first of all, I mean, all the pain syndromes and dysfunctions you mentioned, like those are very emotional, very like life changing
Mhm.
dysfunctions. I mean, you're not just talking about ankle sprains and muscle strains that I treat constantly. It's like, so I have no doubt that those folks willing to try anything probably have tried
Mhm.
most things. When they do find a thing that works, that man, that's why you are booked out for months. And that is why you have become the expert you have become. So it's fascinating to hear.
Yeah, it's really cool. Like you said, people have had chronic pain forever or, dysfunction that no other specialist or physician can really um, make sense of. And you pop a couple needles in, and it's crazy what it'll do.
Love that.
Yeah. What about you?
Yeah. What sucks to admit is my knee jerk response is just everything. I
Needle
mean, if someone just took away my needles, I would just be a completely incompetent.
it.
So I'll put that out there. The imposter syndrome of like I rely so much, and I have relied so much over the past decade that I forget you can treat humans other ways. But I mean, the truth is, okay, you can't use needles. My NFL guys, like I see ankle sprains, grade 1 and 2 muscle strains. So could I rehab them without needling? For sure. I mean, still a big part of my brain is like, no, but the stuff you're doing, even in those subacute phases, is so important. But could you do it other ways? For sure. I used to be a really, really skilled, like, hands manual therapist, like mobs and manips. Like, these were my money makers. Like, I went through NIOPT, Tim Flynn, Julie Whitman, Regis grad. So mobs and manips. I was I was a joint jockey. I mean, which I guess what I'm kind of saying now is I'm less confident with my hands than I used to be. Recently took both lumbar management and total thrust with ice, and I mean, man, I need to work on it more. I need to practice, get reps, but I've taken the training. I think I could help a lot of the backs and necks and stuff.
Hmm.
So yeah, I'm delaying. I'm just talking because I don't know my answer, but it's like, what would I struggle to treat if I couldn't use needles? And again, it's kind of a positive question because I'm saying, what has needling been so powerful for that other things haven't? I go to like some really bad post-surgical shoulders in my past of like, man, I remember, I mean, that for all of the reasons, the smoker, the less healthy, the just the overweight, diabetic. I mean, lots of comorbid reasons, but just that shoulder surgery that doesn't progress the way that it should. Needling has been amazing just to get motion back, decrease pain. A lot of the stuff you said, combat the atrophy that's on board there. I think back in my handsy, like skilled mob and manip days, there were certain brands of headaches that I just really didn't have success with that needling
Hmm.
seemed to give a different outcome. So those are probably my answers. I mean, I think pre-needling or without needling, I got really good with just the dosage for active hips and knees and ankles and
Hmm.
Achilles tendinopathies. So I guess those are my answers. TMD as well. I
Hmm.
was not very good
Totally.
at all. And then when I started just being the needle guy to try something different, still not being a TMD specialist, I started to get those patients that pretty quick, pretty life-changing changes just from starting to use the needling.
Yeah. I think those are three good patient populations. While I don't live in that world as much, I can resonate with that shoulder where you're just like mobbing it over and over again and
Man,
you're not seeing this like huge change. And then you go needle a couple posterior shoulder, or if you can get into subscap, which is tough sometimes on those shoulders, but you can make such a huge change for sure. Cool.
so I guess what we're saying is let's hope we never have that happen. And I mean, maybe
Yeah.
a topic for another time is like I have kind of lived that life of like trained in needling, being in Washington, doing the needling thing, and then kind of being told you should stop. So let's hope that never happens to us. For you
Yeah.
and your pelvic crowd, life-changing stuff, and for me and
Hmm.
my entire career, just hope that needling just is never taken from the toolkit.
Definitely. Very powerful tool. Let's use it.
Okay. Closing words. Give us a sign off.
Oh, heavens. You're just throwing things at me left and right. I don't know. I don't.
We'll work on the salutation, but this is our third podcast. We're dropping these twice a month, by every 2 weeks, bi-weekly.
Yeah.
So
Biweekly. Yeah.
excellent.
Yeah. I
We'll
guess
catch you.
if you're not needling things, start needling things. That's all I have to say.
And if you're listening to the Needle Pod, surely if you've made it this far in our Needle Pod, you're invested.
You're needling.
All right, team. We'll
True.
catch you in the next one. Thanks, Allie.
Bye.